Our next speaker is Mr. Carl Phillips, also speaking as a private citizen.
Thank you. I'm here as a private citizen, but I've been a long-time advocate and researcher on tobacco harm reduction, probably almost as long as anyone, trying to understand and promote the substitution of low-risk alternatives for smoking. My talk is adhering closely to a couple of the questions. First, question 4.4 asks of what is harm, basically, and which harms are important. Harm, this is kind of obvious, must refer to actual harmful effects, which include the increase in the risk of deadly or debilitating disease in the future, or immediate problems of functioning, pain, distress, and so forth, both of which fall into the important category. It's obvious, but what this notably excludes is addiction. Addiction not only is not well defined, either scientifically or medically, but it's perhaps arguably a reason for a behavior that might be a harm, but it is not a harm in itself. And so if the biggest, quote, harm from nicotine use, absent smoke, is addiction, that's hardly a harm at all. Equally important, when calculating harm, it must be considered in net terms, as is done for treatment drugs and everything else that the government properly regulates. Nothing is harm-free, but the harm may be low or trivial compared to the benefits. This is harm and therefore it's bad attitude that you sometimes see from extremist advocates on the internet makes for terrible public policy about any product. But it's what you get if you don't consider the net. So, on the net side, there are psychological benefits from nicotine that improve functioning and treat, in some sense, various psychological conditions, which are highly important advantages of using nicotine rather than being abstinent for many people. But it's not just the medicalized side of things. Acting as if nicotine is purely a treatment for a disease rather than recognizing it as a consumer good that serves other preferences is simply out of touch with the obvious reality. Many people use nicotine because they like the effects, which is also highly important when considering it. If the drug side of FDA is not accustomed to dealing with it, you might consider talking to the people on the food side who regulate things, keeping in mind that the purpose of food is not merely to alleviate starvation. It serves many other purposes. The net health benefits need to be based on probability-weighted but-for choices. So if there's 20% chance that someone would be abstinent but for the option of long-term use of a low-risk alternative and an 80% chance they would smoke, they need to be compared not to the abstinence but to a 0.8 times the risk they would suffer from smoking. It's simply out and out wrong to compare the risk from a low-risk alternative to some unrealistic best-case world. And again, this is not an odd concept. This is how treatment drugs are always considered from a regulatory perspective. And continuing on that thought, sometimes efforts to achieve abstinence themselves are quite harmful. It's already been mentioned that using Chantix is quite hazardous in itself. And most importantly, I would argue, and this was slightly misquoted by a previous speaker, but my previous research points out that someone who tries to achieve abstinence but relapses for just a while, just a couple of more months of smoking, the resulting risk from that smoking is greater than the risk from using a smoke-free nicotine product for their entire rest of their life. And there aren't very many people who don't suffer that relapse. With regard to question 4.6, which asks what FDA and HHS can do to better promote public health in terms of these goals. To best promote public health, the most important thing for HHS to do is to stop lying. I've been documenting disinformation campaigns that are intended to discourage smokers from switching to low-risk alternatives for more than 10 years. And have found that units of HHS are the world's biggest anti-THR liars. FDA has now joined other agencies within that department in publishing disinformation that's designed to discourage smokers from switching to low-risk alternatives. The anti-THR messages encourage people to smoke, and no conceivable amount of low-risk product use could cause as much health harm as has been caused by discouraging smokers from switching to the low-risk alternatives over the last decade. The practice of promoting total abstinence from tobacco use, to quote back from the question that I'm answering, at the expense of discouraging reductions in the harm associated with continuing use, again quoting from that question, is guaranteed to be bad for public health. And finally, very briefly address question 4.7, how these broader outcomes can be taken into account in pre-market evaluation. This is a topic I've been working on. A fair bit of my research over the last 6 months has been on this topic. Don't have time to go into much detail, obviously, but a couple of points to make on this. Focusing on the net effect on the smoking rate is the key to any such modeling. Everything else is a rounding error. It doesn't matter how many people are using these products compared to how many people are smoking. When doing the modeling, it's necessary to look at actual consumer preferences. People act based on incentives. They are not black boxes that just change behavior for no apparent reason. Which unfortunately is the way that most of the models have been done so far. And that is it. I originally planned this for the original 7 minutes that we had available and wasn't able to change my slides, so I will stop with that, but obviously I'm available for questions.
Thank you.
Yes, I was interested if you could explain a little bit more the data behind your statement that if someone smokes just for a couple more months, the risk is greater than from using a low-risk alternative for a lifetime.
Sure. Well, the key to this, and the key at the core of that, is estimating the comparative risk, obviously. And that's based on the estimate that the low-risk alternatives are approximately 1% as risky as smoking. And this is based on the extensive evidence we have about smokeless tobacco, which is well studied, as opposed to the relatively limited evidence we have about the products that are the focus today, and e-cigarettes even less so. But it seems safe to extrapolate that number. Once you have that number and you have the widely established estimates about the toll from smoking, it's a fairly straightforward population modeling exercise to compare people who are smoking for 2 more months and thus experiencing the fraction of the lifetime risk that would result from smoking, and compare them to that relatively low risk. Now that 1% may even be an overestimate, frankly, and there's really very little reason to believe that it's an underestimate. So if anything, that's fairly conservative. Did you want me to go into more detail of the
I just had one follow-up question. Sure. I was wondering if your model included any assumptions about the number of people who continue to use cigarettes in addition to the alternatives, so become dual users and in fact potentially increase the duration of their cigarette use. Does the model have any assumptions about that?
Right. No, so that particular model, as opposed to the ones that I'm working on right now, didn't actually make any predictions. So it says, if this happens, then that will happen. And basically anybody who was a dual user and continued to smoke quite a lot in that model was considered to not have quit smoking. So they were still on the bad side of the equation. They were one of the ones who 2 months more would be as bad as the complete switch. So this was again focused on the complete switch. And again, the message there was, the title of the paper emphasized that that pushing for abstinence only is not necessarily the healthiest option, because again, the relapsing or the dual using, if that includes a heavy amount of smoking, as you're pointing out, is worse than again the lifetime use of the smoke-free product.
So do you have any kind of data about the number or percent of people who maybe would have quit, but instead of quitting, they fall into this category of a dual user?
Yeah, well, that's more of what I'm trying to just start working on now, and in terms of the predictive models of what people are going to be doing. And no, that's quite difficult. And one of the reasons that it's difficult is that second, or whatever it would be, third bullet on this slide right here, which is that people act on preferences as well as on information. There are relatively few people, unfortunately, even today, who understand that that switching to the low-risk alternative really is approximately as good as quitting for their health. And so they choose to dual use for any number of reasons, time and place restrictions and so forth. And they are not being motivated by the same motivation that they might have to quit, that is, the health benefits. So in terms of predicting what people are going to do, that's entirely dependent on what message that they're getting. And to the extent that people are able to start getting the accurate message that dual use is not nearly as good for you as switching entirely to the smoke-free alternative, they're likely to continue to do it. Whereas if they got a very clear message that the smoke-free alternative is basically the same as quitting, whereas dual use is a lot like continuing to just smoke, we would see a much greater change. So the prediction is highly dependent on social factors.
And just one last sort of follow-up question, but a lot of the marketing that we see for products really is more promoting to use when you can't smoke, so it seems to actually be promoting more of the dual usage. So how do you have any thoughts about how to minimize the effect of that to get to the end that you're trying to achieve?
Yeah, well, first off, I'm not sure the characterization that a lot of it is that way is accurate, but certainly some of it is, although some of it goes as far as the companies legally can in order to encourage switching for harm reduction purposes. But not only is the government actively lying about the lack of benefits from harm reduction, but it strictly prohibits merchants from telling people the correct information. So there's a very straightforward answer to that. Allow those who are selling pharmaceutical nicotine products, e-cigarettes, smokeless tobacco to explicitly point out that this is a lower risk alternative to smoking, or better still, change the labeling that's on the packages so that it says that, and also change the labeling on cigarettes, trying to aim people toward the lower risk alternatives that they could be using.
Picking up on that question, on Corinne's questions, what about a situation where you talk about the manufacturers of these alternative products being able to talk about the lower risk as you describe it? What if the same person is marketing the combustible and the lower risk products?
Well, it's an interesting question, but there seems to be a willingness of those who are marketing both products to cannibalize their own customer base away from the combustible products and to the low-risk alternatives. From what I've seen, I believe that this is extremely genuine on the part of many of these companies, and if they were allowed to if they were allowed to say more, they would, and they would be happy to lose cigarette customers in favor of their smoke-free business.
All right, and again, a slightly related follow-up. In your last slide, you talk about an important consideration being modeling actual consumer preferences.
Yeah.
And you've spoken a little bit about some of that in the discussion we've just had. Are there other types of consumer preferences that we haven't talked about that you think are important to this discussion?
Well, I mean, right. So there are the consumer preferences to consume nicotine rather than not, which is true for many people, many of us in this room. There are the consumer preferences to engage in a socially acceptable behavior. And so I recently presented a paper which models the use of low-risk alternatives, e-cigarettes in particular, as a bit of a social contagion. So that is, the greater the use of these products, the more people who are using them in one's social circles or that you encounter, the more likely any given individual is to switch. Individual being, of course, a current smoker who's a potential candidate for harm reduction. So that's an absolutely critical consideration. As I mentioned, there is the information coming from both trusted sources, the government, and advertising sources, which people, of course, don't fully trust, but do gain some information from. That makes a lot of difference in terms of people's understanding and so forth. But I mean, I think the real key to keep in mind is that smokers are not idiots. They do not believe that what they are doing is they understand that what they're doing is as harmful as we all know it to be. And yet they're still choosing to do it because given the choices just between abstinence and smoking, abstinence is a poorer choice for them. If given a third alternative that could trump both of those, then a lot of people would make the move to it. The question is basically, how are they going to find that out? How is it going to become socially acceptable? It will. I think in both cases, the answer is it will happen. The question is whether the U.S. government, among others, is going to help it happen or is going to slow it up.
Thank you. In that case, thank you very much.
Thanks.